All right. Thank you very much for the intro and the invitation to speak here. My name is Maarten from Smeden. Can you hear me at home, by the way?
Yes, we can.
Very good. All right. My name is Maarten van Smeden. I'm an associate professor in Utrecht. I'm a statistician, medical statistician. So I work in this hospital. And I'm also an epidemiologist. So the title of my talk is about prognosis-based medicine, merits and pitfalls of forecasting patient health. And because this is a forecasting conference, I will talk more about the pitfalls because they're more fun than the merits. And my slides are available. And from the first talk, I heard that this is actually for the social good of forecasters. I didn't know, but there you are. You can find them very easily on my slide share. So prognosis, what is it? It's actually the study of risk. In other words, typically in terms of probability of future outcomes and events in patients. It actually comes from ancient Greek. It actually means just forecasting, right? And that it was important was already recognized by Hippocrates many years ago. So about prognosis research, which is what we do, is really the study of future outcomes. So events, or what we typically call endpoints, among individual patients in a certain health state. And that health state is a starting point in order, for many reasons, among which to inform the patients about what will happen to them. Will they die within 5 years? Will they survive another 20 years? Will they get a heart attack within 10 years? That kind of ideas. And also family members often want to know this kind of stuff. But also the healthcare professionals. They also want to know what will happen to this patient. Should I intervene? So in the end, obviously, why we're doing this is to improve health. And we do that primarily through trying to inform, to, well, get prevention early started, to improve treatment decisions when people are ill, but also, for example, risk stratification in trials. If you really want to know more about this, this is a nice book to start reading, nice introduction book. And prognosis research is actually quite broad. We do quite a lot of things. First of all, something we call overall prognosis research, which is just the occurrence of a health outcome within a geographic region or over time. Imagine COVID, just the burden of COVID over time. That's a type of overall prognosis research, or the average risk of having or experiencing the health outcome. The second part of prognosis research, or the second element of prognosis research, is prognostic factor research, which is just trying to identify the predictors or the features or whatever you want to call it associated with a certain health outcome. Third one, important element of prognosis research is predictors of treatment effect. What predicts whether somebody actually benefits from a treatment? There's a large literature called Heterogeneity of Treatment Effects. If you want to read that, there's a path statement in the Annals of Internal Medicine quite recently, if you're interested. And there's also prognostic model research, modeling combinations of factors to predict a health outcome for individual patients. And today I will focus on this below part, but prognosis research is much broader. So what are we doing in this kind of research? Well, for example, just develop risk scores typically to predict the risk of cardiovascular disease within 10 years for an individual patient, which is a long-term thing, or a short-term thing like the risk of a patient dying within the hospital after they had a heart attack, or the risk of severe mortality or severe morbidity after an ICU admission, or the risk of hospital admission once you got COVID. These are all kinds of types of problems that we try to deal with. Not just theoretical. You can download this app. This is the app, one of the apps of our hospital that is actually used, which is about cardiovascular disease, vaartrisico in Dutch, which is just vascular risk. And it's as simple as you see. It's a simple app where a medical doctor typically fills in some things like the age, whether they're a smoker, and what's their gender, and they get a risk, 4% risk in this situation for this particular patient. And it says that's a low risk for some reason. And this is not new at all. This is one of the most famous examples of a model that is still used today, but actually comes from 1953. And those of you who have children might know it. It's called the APGAR score. Anybody familiar with that? It's a very simple system with 5 predictors: activity, pulse, grimmage, appearance, and respiration, which abbreviates as APGAR. And for each of those predictors, you can score whether, for example, the activity is active. This is all for, by the way, for babies, right? Babies that just are born within the first couple of minutes. So you can actually do this APGAR scoring for newborn babies and then decide on whether they're pink enough, whether they are crying enough, that kind of stuff. And you sum them up and you get a total score for an individual baby. And the idea here was that if you have a very low score, the prognosis of the baby is actually pretty poor. Approximately 9 to 14% dies with a risk score lower than 2. And with 8 or higher, that probability is only 0.13%. Of course, these are data still from 1952. And the interesting thing is it's 50 years ago that this model was developed and it's still used. But this is not the only model, obviously, that we're using. There's a website that you can also access with freely available prognosis calculators. There are more than 500 of these kind of models available. And according to them, approximately 65% of US physicians actually use this website on a weekly basis. How does that look like? Well, still very, very simple. So this is a pretty popular one called the Chad-Vask score, which calculates the risk of having a stroke after arterial fibrillation. And it's as simple as you see it. It's based on the age, the sex, the heart failure history, hypertension history, stroke history, vascular disease history, and diabetes history. So you can just fill it in also as a patient if you want, and you can get a score of 4, which is associated with a risk score, a risk of 4.8% per year risk of actually getting a stroke. All right, so it's as simple as this. And we have a lot of those scores. I just summarize a few of them. We have more than 400 models for COPD. We have more than 300 for cardiovascular disease. And we have more than, let's see, 160 female-specific cardiovascular disease models. We have models for almost everything. I was pretty proud that I made this overview, and then my colleague, actually from Oxford, told me, well, you missed a lot of them. These are 260 systematic reviews of these prediction models. So probably we need a new review of reviews. And of course, many of these models are very simple, but as you understand, also in medicine, there's an increasing interest in artificial intelligence. So this is a figure that we recently published about all studies divided by the total number of studies that actually mention artificial intelligence. So you can see that it's increasing quite rapidly at the moment. So how about these simple risk scores that I just showed you? Why not replace them, given this AI interest? Because historically, as I showed you, these risk calculators are often very simple. And they're based on practical considerations like easy calculation, often developed using a logistic regression with just 10 predictors and then rounding the regression coefficient. So it makes it easier to calculate for a medical doctor. And what is the benefit of them? Partly is because you can explain this to some degree to medical doctors, what goes in, and they believe it sometimes. We also have to do with pretty small data sets often. It's rare to have thousands of patients on a similar disease. It's typically a couple of hundreds. And so we also deal with a small number of candidate predictors, but things are changing quite dramatically. Of course, there is the digitalization of electronic health records, where there's new opportunities to actually build prognostic scores within an electronic health record system. We have larger data sets also because of those electronic health record systems. We're interested more and more into precision or stratified medicine, which is a movement towards more individualization of medicine. We have access to high velocity data coming from wearables or in the ICU. So this seems like the perfect conditions for AI, machine learning, data science-based predictions, and maybe even automated. The best thing that can come from that is that they make me obsolete. And obviously, that's not just theory. There's also some practical examples where AI has done actually pretty well. I'm sure you've heard about IBM Watson winning Jeopardy, the game show in the US in 2011, being better than a human. What you might not know is they tried to school IBM Watson as a medical doctor, trying to let IBM Watson decide whether a patient, what kind of treatment for cancer patients had to do, and it actually failed to do that. And this is a very controversial paper, very interesting paper to read. Got a lot of attention, where they compared whether there was actually some evidence for a benefit of these more complex models that we see more and more versus the ordinary simple logistic regression types of models. And you can see where this is going. If you look at the studies that are considered low risk of bias, so didn't have a big problem, and these are all studies that compared logistic regression to some kind of machine learning type of algorithm, you can see that there was no difference at all in the area under the curve between the logistic regression and other types of machine learning models. It is controversial and also not liked by a lot of people. But maybe it's time also to check these promises of these machine learning types of algorithms. We've written a nice paper, I think, about that, because there's still a lot of expectation, but not a lot of evidence yet, or a lot of use cases where it actually helped us. And that it's important that we know pretty sure. This is a very nice paper, I think, that actually compared AI assistance in liver cancer diagnosis. And what they saw is that if the model made a correct prediction, it improved the likelihood that a pathologist, so a medical doctor, making a correct diagnosis, it increased the odds by a rate of 4. But if they switched the outcomes, so made the wrong prediction, the odds ratio goes down dramatically, making it less likely that the medical doctor made the right decision. So bad prognostication can actually lead to bad decisions, which is obvious. So then the question is, can you just develop such a prognostic model, apply it in patients without any quality checks or validation? Well, yes, you can, and no, you can't. Because more and more regulations are actually becoming applicable. First one is obvious, the GDPR, about well, it's medical data, so you have to be a bit careful. But there's more and more regulation coming into place that doesn't allow you to just develop those models and apply them in practice. And one of them is the medical device regulation. So a prognostic model, a forecasting model, might actually be evaluated as a medical device, especially if you put it in software. Then it's suddenly considered a medical device and you have to, well, abide by the regulations. There's also related kind of regulations like the IVDR, the Artificial Intelligence Act that the EU is working on. There are all kinds of ISO standards that you might need to consider. And for example, in the Netherlands, we have now the Electronic Data Exchange in Healthcare Act that may also apply. And the issue here is that those regulations are not uniform across the FDA in the US, the European Commission, which does it in Europe, or for example, in the UK, the MHRA. And it's a real issue. And especially in radiology, they take this kind of stuff very seriously. And this is a very nice recent blog post by someone who actually looked at all those AI algorithms that are now used in radiology. And she describes that actually, if we're going with the pace that we're doing now, half of those AI products that are actually used in radiology can no longer be used clinically after May 2024 because the regulations become harder again. So this is the problem, obviously, in medicine. There is a lot of regulation hassle. So should we even bother developing new prognostic models? Yes, I think so. And also no. Yes, because prognosis is vital. Estimating prognosis is actually very complex. I'm not sure whether you ever tried that with your doctor. It's always fun. Ask them about the diagnosis and they're fine. Ask them about the prognosis and they say, we'll try this treatment. It's very common for medical doctors to feel very uncomfortable with making very precise predictions about what will happen to your health for good reasons. And partly because humans are complex, and especially now we're living longer and we are more knowledgeable about diseases. So we diagnose more diseases. So people are living with one or more diseases or health impairing conditions more and more, which we all need to take into account somehow. That's not to say that we shouldn't try, right? It's very important. Adequate prognostication is vital to disease prevention and treatment decisions. If you don't know the prognosis, it's very difficult to decide on the appropriate treatment. So there are also a lot of opportunities here to improve prognostication in healthcare. And the fun thing is that industry by now has noticed, because we see a lot of uptake in black box types of algorithms that are where it's not even clear what kind of data they actually use, which leads to very strange things like this. This is an example of an actual algorithm for sepsis. So they try to predict whether somebody gets sepsis, which is a very bad condition to get. And at some point, so this is actually hospitals pay for this algorithm. And at some point, people suddenly realize that the big predictor in this algorithm is that the patient got antibiotic treatment, which is the treatment for sepsis. So they're predicting with already treatment given, which is not very helpful. So the question is, obviously, should we make those new prognostic models or should we stop? Well, I made as a joke once this simple flowchart, but it's now in a book, so it's apparently official now. So it starts obviously with the question, is the prediction actually needed? If yes, do you know for whom? If yes, do you actually have data on such patients? If yes, is there already an existing model? And we've seen many models already. Second part is you say no, I suggest you check again. Then, is that actually a large data set? Because we need quite a large data set. The following point is whether your predictors are very unique. And unfortunately, in this setting, you don't want unique predictors, because if you have unique predictors and measured nowhere else, your model cannot actually be applied in another setting, right? So you need also some kind of common predictors to make a useful model. But looking at this now, I think it's even too narrow. It's again focusing too much on whether you have the data and whether you think it's interesting. I think the real problem is there is a very complex pipeline that makes lots of prognostic models fail, never to be applied in practice. And the first reason is simply because we're making models that are not fit for purpose, because again, they may have too complex predictors. They're developed on the wrong patient population. And the second point, I think, is even more important, that most of those models that are developed are never validated, never externally tested at all. So they're just sitting in a paper, and that's where they, in essence, die. But there are more steps afterwards. There's no implementation often, because you have to build software, and we're not good at building software, at least not the researchers that are actually doing this kind of stuff. And even if you do all that things, there are many reasons why prognostic models might not be adopted. Just because if they're not considered useful, they're not used. Just because they're not trusted, or whether if the model is not transparent enough, all kinds of reasons why your model fails. And obviously, it's very important to think about these things before you actually start developing a new model. And the most attention, also from me, to be honest, is going towards the first part of this model development. Do I have enough data? Can I get this published? And not later on, will medical doctors actually use it? And we've tried to sort of give an overview of all the guidance that's now existing, not only in this first phase, but also in the later phases. So this is a review we made. And based on this review, our Ministry of Health asked us to write the Dutch guideline for AI-based prediction models, which was published quite recently and actually has an English version. So if you want, you could read it. And what we do there is we try to, with a lot of people from the field, not only statisticians, but also medical doctors and people with understanding of regulations and et cetera, et cetera. And we faced those, the phases of prediction model development or prognostic model development into a first phase where you collect data, the second phase where you developed the prediction model or the prognostic model, the validation, the software, the actual evaluation of how well it actually works in practice, and then the implementation. So my concluding remark, prediction is very difficult, especially if it's about patient health. And I run out of time and also out of presentation, so I'm happy to answer your questions.
Could you please repeat the question?
Yeah, I will try. They do not. No. Yeah, so there is a whole discussion about confidence interval for probabilities. I'm not sure whether you're familiar with that discussion, but it's challenging if you think about it from a statistical point of view, right? It's the observations are 0, 1, so confidence intervals should theoretically go from 0 to 1. So there's the technical part. There is some developments and some papers that my colleagues have written about sort of the stability of those point estimates, which relates to this. It's actually quite complex because you have to sort of consider a true model. I don't want to go into too much statistical, but if you leave that out, you can talk about stability. But there's no guidance yet. And in medicine, we're very much relying on guidance documents. That's how at least the medical doctors are typically trained. So as long as we don't tell them to do that, they won't do it. And especially in MD-Calc, no, they do not have those confidence intervals because, well, there's no regulation that tells them to do that.
In the slide that you outlined, most of them are related to practice, so it means I do the work in the phase, it's actually difficult to implement something. So I'm wondering how much of the research is helpful in that respect. And because it's difficult, it's not working directly. So how much important is important where?
Yeah, so very good question. So your question is how does this actually work when you're not working in a hospital and you want them to use your algorithm, and how much of these sort of your related question, I guess, is that a lot of research is in a sense wasted because these prediction models will never, or prognostic models might never be used. Yeah, so a lot of these things are still sort of academic exercises, and I recently heard this one talk by somebody who said, if you don't know statistics, start by developing a risk score, because that's the easiest thing you can do in statistics. So a lot of our sort of homework exercises that end up in the literature, and it becomes a bit scary once they are taken seriously, because obviously these models, we can laugh about it, but they're used for very important decisions about patients, and sometimes life or death decisions. So pretty important sometimes. And so the way you can get it to the market is very difficult. So it has to actually apply it. So some people are very effective in doing it in our hospital, for example. They know the right people and they can build it into the electronic health record system. The other way to get it is to get it recommended by important people in the field, or the important subsections of medicine in the field. So essentially, again, getting it into the guideline. If you get it in the guideline, you're golden, right? Then they're going to use your model. If you don't get it in the guideline, it's much harder, unless you do it indeed in a very local setting. And there is a reason to do it locally, because the regulation is a bit less strict. Again, these regulations are very much in development and pretty recent. Victoria, APGAR didn't think about regulation at that point, but we have to.
Okay, I think in this